Bismillahirrahmanirrahim. Assalamu alaikum. So today we are going to study about the peritoneum. Now, first imagine a balloon and right now forget about the abdomen just for 1 minute. So now, push your fist inside the balloon without puncturing it. What happens? The balloon wraps around your fist and then you notice something important, and that is your hand is not actually inside the balloon. Instead, your hand is pushing the balloon inward. Exactly the same thing happens in the abdomen. Okay, so this single concept explains almost the entire chapter about the abdomen. Now let's come back to our main topic, and that is peritoneum. Okay, so according to Snell's, peritoneum is a thin serous membrane that lines the walls of the abdominal and pelvic cavities, covering the abdominal viscera. Okay, now there are two words here. First, it is a thin, that means it is a very delicate membrane, and then the serous membrane. So this word serous membrane is extremely important. A serous membrane has actually simple squamous epithelium. Simple squamous epithelium is also called the mesothelium, and the connective tissue beneath it, that is called the serous membrane. So according to our notes here are actually saying that mesothelium, simple squamous epithelium, is actually a thin serous membrane that is forming the peritoneum. Now why is it called serous? Because it secretes serous fluid. This serous fluid lubricates organs, decreases friction, allows free movements, and without this fluid actually every breath, every bowel movement, every stomach contraction would produce friction and pain. So that's why Allah Azza wa Jal has created this to reduce the pain and the friction. Now let's study about the layers of the peritoneum. Okay, so here we have got the layers of the peritoneum. There are actually two layers. One is the parietal peritoneum, the parietal peritoneum. Now think like the parietal is equals to wall. Parietal is equals to wall. That means it lines the abdominal wall and the pelvic walls. Parietal is equals to walls, and that means it is never going to cover organs. It is actually lining the walls, not covering the organs. Now the second layer is the visceral peritoneum, that is actually inside the parietal peritoneum. Now think of the visceral is like organs. Visceral is equals to organs, parietal is equals to walls. So it actually covers stomach, liver, spleen, intestines, and other viscera of our abdomen. Okay, so easy memory trick here is P is equals to parietal is equals to periphery. P for parietal, P for periphery is equals to wall, and V for visceral, V is equals to viscera, and viscera are actually the organs. Okay, now let's move towards the peritoneal cavity. What is the actually peritoneal cavity? So let's study about this. Okay, so now you have to imagine the balloon again. We are again considering this example of balloon. So between the two balloon walls is a tiny potential space, and that is the peritoneal space or peritoneal cavity actually. So what's important here, that normally it is not an empty space. Okay, it contains only a small amount of serous fluid, so it is called the potential space. That's why it is called the potential space, because it is containing, because under normal conditions the layers are almost touching each other. Okay, that's why it is called the potential space. Peritoneal cavity is also called. Now why is it called a potential space? Because normally no large spaces exists. It is covered by the serous fluid, and only when the ascites, blood or pus collect here, the cavity becomes an actual space. That's why it is called the potential space, because it is not an actual space. Space means cavity, and the cavity is something that's empty, but it is not empty under the normal conditions. Okay, now why is peritoneal cavity closed in males? Let's study about this. So this is a favorite Viva question here, that in males there is no communication between the peritoneal cavity and the outside world. Therefore it is called completely closed, or it is called completely closed in case of males. But now why is it open in females? Because in females the cavity communicates with the exterior through the ovary, uterine tube, and then that leads to the uterus, and then leads to the cervix, and eventually vagina. So this communication is actually indirect, but it is real. So that is why our book is mentioning the cavity is open in females. It does not mean the abdomen is open, okay? That doesn't mean like that. It means there is a continuous pathway from the outside to the peritoneal cavity. That is, it is connecting somehow to the environment. Now, the clinical importance here actually is this, that because bacteria can travel upward through this pathway, in case of females through the vagina or then to cervix and then to uterus. So actually the females have a risk of pelvic inflammatory diseases that are called the PTD. They have a much higher risk of these diseases, and there is also a risk of spread of infection to the peritoneum, that any infection in the uterus can also spread to the peritoneum, and it can also actually leads to the peritonitis. Okay, so that's was some clinical importance point here. Now let's study about a tissue that is present here in the peritoneum, and that is called the extraperitoneal tissue. So actually our book mentions another layer, and that is called that is actually between the parietal peritoneum and the abdominal muscles. So between the parietal peritoneum and abdominal muscles lie extraperitoneal connective tissue, and that is the extraperitoneal tissue. And what is its functions? So its function is it anchors the peritoneum to the wall, it contains fat, and it is around kidneys. If it forms peritoneal fat which supports the kidney, it forms peritoneal fat around the kidneys. Okay, then now let's study about the nerve supply of the peritoneum. Okay, so the parietal peritoneum is actually supplied by the somatic nerves. Somatic nerves are, for example, the intercostal nerves and the phrenic nerves. The phrenic nerves are the phrenic nerve actually supply the central diaphragm, if you remember. And what are the characteristics here of the sensory supply? That it is pain sensitive, it is pressure sensitive, it is temperature sensitive, it is touch sensitive, and if pain is sharp and localized, so it can also detect that kind of pain. Okay, pain sensitive and somatic supply. Okay, that was about the parietal peritoneum. Now let's move towards the visceral peritoneum. So the visceral peritoneum is supplied by the autonomic nerves, and its characteristics are it is insensitive to actually touch, it is insensitive to cutting, and it is insensitive to temperature also. But on the same hand, it is sensitive to stretching, that means distension, and it is also sensitive to any kind of chemical irritation. Okay, and usually the pain that is felt in the visceral peritoneum, it is usually dull, it is poorly localized actually, and it is mostly the referred pain here. Okay, now let's move to a clinical example here, or a clinical point here that is mentioned in our book, and that is about the appendicitis. So what happens in appendicitis? Initially only visceral peritoneum is inflamed. Okay, and so if the visceral peritoneum is inflamed, we know it is not very much sensitive to pain. So the vague pain, there is a feeling of vague pain around the umbilicus. But later what happens, that parietal peritoneum also becomes inflamed, and the pain shifts to the right iliac fossa and becomes sharp and localized. So pain shifts to what? So in case of appendicitis, there will be a pain in the right iliac fossa. Okay, right iliac fossa, and it is usually sharp and localized. So this is why the patient describes pain migration. Okay, in the patients they usually mention that there is a pain migration, that there was a sudden visceral pain, vague pain around the umbilicus level, but then the patient will told you then that it has shifted to the right iliac fossa, and it is more of localized and sharp. So you will eventually diagnose that it is appendicitis. Okay, now let's move towards the next heading, that is about the greater sac. Okay, there are actually the divisions of the peritoneal cavity. So the peritoneal cavity has actually two parts. The first part, that is called the largest compartment, and that is called the greater sac. So it is the largest compartment and it extends from the diaphragm to the pelvis. It extends from diaphragm to the pelvis, the greater sac. Okay, and almost all the abdominal organs lie in relation to this compartment, this greater sac. Now let's move towards the lesser sac. The lesser sac is also called the omental bursa. Omental bursa. So it is actually behind the stomach. The lesser sac is present behind the stomach, and it is a hidden space behind the stomach, and this space is called the lesser sac or omental bursa, that because it is present behind the stomach, and you can think of it as a pocket behind the stomach, like some kind of small pocket. Now let's there is also that, but there is actually not a complete division. the greater sac and lesser sac are connected to each other somehow, and so let's study what is the communication between them. So the greater sac communicates with the lesser sac through the epiploic or omental foramen, and this opening is also called the foramen of Visceral. The foramen of Visceral. The epiploic or omental foramen actually is connecting here. We will study about this lesser, the epiploic omental foramen, where is it present, but right now just remember that the communication between the greater sac and the lesser sac is via the epiploic foramen, and the epiploic or omental foramen is also called the foramen of Visceral. Okay, now let's study about this foramen in detail. So what are the boundaries of these foramen of Visceral? Okay, this is actually a very high yield, so I want you to focus here. Okay, now about the epiploic or omental foramen, the boundaries. So the anterior boundary here is actually formed by the free edge of the lesser omentum. Free edge of the lesser omentum containing the portal triad. Free edge of lesser omentum containing the portal triad, that is the proper hepatic artery. Now what are in the portal triad? So in the portal triad we have the bile duct, the proper hepatic artery, and the portal vein. These three structures are called the portal triad, and these actually are containing, and these are actually present at on the anterior side or anterior border of the epiploic foramen or the omental foramen. This diagram is not very much clear, but you don't have to worry. I will show you a picture from somewhere else to make you understand it completely. You don't have to worry. Okay, then now move towards the posterior boundary. So the posterior boundary is formed by actually the inferior vena cava, and then the superior boundary here is formed by the caudate lobe of the liver. That means there is this epiploic foramen is somewhere there. Okay, somewhere at this point where I'm mentioning actually. Somewhere at this point we have the epiploic. That means first part of the duodenum will be the inferior boundary. The superior boundary is by the caudate lobe of the liver. Caudate lobe of the liver, remember. And then in the anteriorly we are not shown here, but anteriorly there will be present the portal triad, and the posteriorly inferior vena cava is present at this. So exactly at this point we have the epiploic foramen or foramen of Visceral, which is actually connecting the greater sac with the lesser sac. Okay, now let's see a diagram here. Here you can exactly see the boundaries of epiploic foramen. They're actually where the epiploic foramen is located. So all this space, imagine all this space around here is the greater sac. Now this space that is exactly behind the stomach, this space here is called the lesser sac. Now this lesser sac here at this point is communicating with the greater sac here, and this point here is called the epiploic foramen. Now on the epiploic foramen you can see the anterior boundary here. The anteriorly, because this is a transverse section shown here. Okay, that's not a longitudinal section. The previous picture I was showing you, that was longitudinal section. On that picture we were able to see the superior and the inferior boundaries. Okay, but in this picture we are able to see the anterior and the posterior boundaries. So anteriorly what we have? Anteriorly we have this portal triad and epiploic foramen, and in this portal triad we have the bile duct, the portal vein, and the hepatic artery. Now look, the portal vein and the epiploic foramen are actually in parallel. That means it is in anterior, but it right in the front of the epiploic foramen. Then about the bile duct is anterior, but I am just telling you a little detail here that bile duct is actually a little, you can say, on the right side. Okay, right side, but anteriorly, but on the right side. And then that means it is laterally, and then the hepatic artery is also on the left side. That means it is anteriorly, but on the left side, that is also laterally. So exactly portal vein is present anteriorly, but this we will talk that this whole portal triad is present in the front of the epiploic foramen, and posteriorly we have the inferior vena cava. Okay, so that was all. Now there is also a point that is about the why is the lesser sac important. What is actually the importance of the lesser sac? So let's study about this. Okay, so the importance of the lesser sac is surgeons can enter the lesser sac through the epiploic foramen to approach structures behind the stomach such as the pancreas, because from the front there is stomach, and if the pancreas is actually present beneath that is the pancreas, and the pancreas is actually present behind the stomach. So if the surgeon tries to approach it from the front via the greater sac, then it is a great chance that the stomach will be actually lacerated or injured in that case. So from posteriorly via the lesser sac, the surgeons actually approach the structures like pancreas. Okay, and that was all about the greater sac and the lesser sac. Now we will talk about the omental and the peritoneal ligaments and some retroperitoneal terms and like this. So now in the second part we will discuss about the peritoneal relationships, omenta and development. So so first we have there is a difference between what is the difference between the intraperitoneal and the retroperitoneal organs and this term. Okay, so this one is actually one of the most misunderstood topics, and many students think actually that the intraperitoneal means the organ inside the peritoneal cavity and the retroperitoneal means the organ outside the peritoneal cavity. So actually this is very wrong concept, because our book clearly states that no organ is actually inside the peritoneal cavity. I told you about this when we started the lecture. There was, before even starting the definition, I made you clear this concept that you have to imagine peritoneum like a balloon, and if you punch the balloon, you cannot enter the balloon. Are you going to enter your hand into the balloon? No, your fist will not enter. You are actually punching the balloon from behind, and that is actually making some kind of cavity, and in that cavity we have our organs. So that means they are not present inside the balloon. Okay, and this similarly the stomach appears to be inside the peritoneal cavity. Same goes for the stomach. We do think that the stomach is actually present inside the peritoneal cavity, but that is not. It is actually covered by the visceral peritoneum, but it is not present inside the peritoneum cavity. Okay, therefore peritoneal cavity contains only serous fluid, not organs, because we have talked about the peritoneal cavity is the space between the parietal and the visceral peritoneum, and that is a very small space, and that is actually called the potential space, and there is a little of you can see the serous fluid here. There are not even a single organ is present in the peritoneal cavity. Okay, now let's study about this term that is called the intraperitoneal. So what is the definition here? What does intraperitoneal actually means then? So an organ is called the intraperitoneal when it is almost completely covered by the visceral peritoneum and is suspended by a mesentery. Now what is a mesentery? We will discuss it later, but just you have to remember that any organ that is completely covered by the visceral peritoneum and is suspended by the mesentery, that is called the intraperitoneal organ. And remember, the intraperitoneal organs are actually mobile, and you have to notice the word here. I have highlighted the word that almost completely covered. Now why do I mention almost completely covered? Because one small area remains uncovered where vessels and nerves enter. Because the organ needs to have its vessels and nerves, so that area cannot be covered by the peritoneum, only that area. Okay, but mostly it is covered. Now what the characteristics here are, it is actually mobile and it is covered by the visceral peritoneum and it is suspended by the mesentery. So there are examples of some intraperitoneal organs. So what are the intraperitoneal organs? There is stomach, we have the jejunum, we have the ileum, we have the spleen, and other common examples include liver, first part of the duodenum, okay, the appendix, the cecum, the transverse colon, the sigmoid colon. So there is an easy memory trick here. Now imagine an apple hanging from a tree. Okay, the apple can swing. Why the reason? Because it hangs by a stalk. Okay, that's why it can swing. So similarly, intraperitoneal organs hang by a mesentery and therefore they are mobile. Okay, now let's move towards the next term that is called the retroperitoneal organs. So for the retroperitoneal organs, imagine placing a book against a wall, because it is better to understand with the help of examples. I think I love to study with examples, and I always make examples in my mind when I want to picture memory something or make something into our long memory. Okay, so imagine an apple hanging, so imagine a book against a wall, and now if a book is against a wall, it cannot move. Okay, and the retroperitoneal organs actually behave very similarly like that book against the wall. Now the definition here is the retroperitoneal organs lie behind the parietal peritoneum and are covered only on their anterior surface by the peritoneum. So actually the Snell states they are partially covered by the visceral peritoneum. According to the Snell, partially covered by the visceral peritoneum. Meaning, what does that mean? That actually means that the anterior surface is covered and the posterior surface has no covering. Okay, the anterior surface of the organ, the retroperitoneal organs, will be covered by the peritoneum, and the visceral surface and the posterior surface will have no covering. And the characteristics here are fixed, because we talk about the book example that if the book is pressed against the wall, it cannot move. Okay, and it is less mobile, and it is behind the peritoneum. Now the examples here are the pancreas, the ascending colon, the descending colon, and the most part of the duodenum, except for the first part, because the first part of the duodenum, we already told you that it is actually the intraperitoneal part. Now there are additional important examples here, and that is remember this. To remember all these examples, you have to remember a classic mnemonic, and that classic mnemonic is called the SAD pucker. SAD pucker. Okay, SAD PUCKER. SAD pucker. SAD pucker, and that is a mnemonic to remember the examples, the additional examples of the retroperitoneal organs. And SAD pucker. Why the SAD pucker? What does we mean as SAD? S for suprarenal gland, A for aorta and inferior vena cava, D for in SAD, D for duodenum. The duodenum will be the second, third and fourth part. The first part is the exception here. And then pucker, PUCKER, pucker. So P for pancreas, pancreas will be, but except the tail portion of the pancreas. Okay, except the tail portion of the pancreas, we will have the. Then we have the pucker, U for ureter, C for colon or ascending, that can be ascending and descending, K for kidneys, E for esophagus, esophagus only abdominal part of the esophagus, and R for rectum, and rectum is actually partly retroperitoneal. So SAD pucker, this is a mnemonic to remember, to memorize the retroperitoneal organs. Now there are two terms written here, as you can see on the screen. First is the primary retroperitoneal organs, and the second are called the secondary retroperitoneal organs, and this is a term actually frequently asked in the Viva. So what are the primary peritoneal organs? Retroperitoneal organs. So these organs develop behind the peritoneum. They develop behind the peritoneum and they actually remain there. That's why they are called the primary retroperitoneal organs. And the examples are kidneys, ureters, the suprarenal glands, the aorta and the inferior vena cava are actually called the primary retroperitoneal organs. Then what about the secondary retroperitoneal organs? So actually the secondary retroperitoneal organs, these organs start as intraperitoneally. That means they are actually developed intraperitoneally, but later their mesentery fuses with the posterior abdominal wall, and okay, because the intraperitoneal organs are hanged by a mesentery, so what happens later, their mesentery fuses with the posterior abdominal wall and they become fixed, and that's why they are called the secondary retroperitoneal organs. And the examples here are the pancreas, that is except tail again, the duodenum except for the first part, the ascending colon, the descending colon. Okay, and that was about the retroperitoneal organs. Now there is one more term, and that term is actually not mentioned in the cells very clearly, and that is called the subperitoneal organs. So what are the subperitoneal organs? So subperitoneal organs, these lie below the peritoneum in the pelvis. The subperitoneal organs lie below the peritoneum in pelvis. The retroperitoneal organs lie behind the parietal peritoneum, but they lie below the peritoneum, that means in the pelvis part. Okay, and the examples here are urinary bladder, the lower rectum, the cervix and the uterus. Okay, so that was all about the subperitoneal, retroperitoneal and intraperitoneal organs. I think the lecture has been long enough, so we will study the rest of the peritoneum in the next part. Thank you so much.